Thank you, and thanks, Walt, for putting this on and inviting me to come out and speak this morning. And again, thanks to Jamie for that lecture a minute ago. I think that that topic and that is kind of on the cutting edge of EMS, and I think it's something that we are really focused on and should be focused on and taking care, especially in our state. So again, today I'm going to be talking about some aeromedical transports and talking about fixed wing and rotary wing service. The beginning of this topic or this lecture, for those that are in flight medicine, maybe you may know a lot of this stuff, but there's a little bit of kind of some baseline understanding of what goes into flight medicine, what is it about, the risk and benefits, and an overall kind of overview. And then we'll talk a little bit about some interesting papers that I've found that have been published in the past year or so of how to be able to treat some of our patients. So again, this is me. I'm Blake Davidson. I'm originally from Arkansas. So for UK fans, I'm sorry. For U of L fans, you're welcome. But I came up here for residency. I did my emergency medicine residency at UK, graduated a few years ago. I did an EMS fellowship down in Birmingham, Alabama, and came back what I consider to be up north to continue my career and work at UK now. So I'm the EMS medical director. I'm the medical director of our transport service at UK. I don't have any disclosures. Nobody pays me enough money to care about my thoughts. So what we're going to talk about again today is the basics of air transfer, some of the costs associated with these transfers. Does transferring patients by helicopter actually result in a better outcome for the patient? And then a little bit of that literature review. So I'll start off with a case that I had during fellowship. So I was working out at Talladega Motor Speed Day. Whenever we work that, they have a medical center that's on site. You have like a few rooms. We actually have an x-ray machine that's out there. But I was working the overnight shift. So we work, you staff it from Thursday morning until Monday morning. So I'm working Thursday overnight. As soon as I walk in, I walk in the door and I look over, they had a patient in my room already, and he was sweating. So naturally I started to sweat. There's a good old boy from South Louisiana. He had come up, he was just setting up his RV, come his family, and started having some chest pain whenever he got there. So we got this EKG, and I started sweating a little bit more, right? So right then, normally we have a helicopter that sits on a helipad that's right outside the medical center, and it's super nice to be able to have this available for us. But we had just actually had a fatality-related incident with that service that normally provides that transport about a month prior to the race, and so we had to activate another local helicopter agency. Meanwhile, while we're waiting on, we get another EKG. This is the next one, and then right as they landed, this is our next guy. So it's pretty sick. So they landed, and I have a review on this later. So this is kind of like one of the cases that we'll have that this patient really benefited from having helicopter transport or rotary wing transport. So we have to talk about some downsides of fixed wing of transport in general. And so obviously this is a very costly service that we provide, something that is not necessarily cheap to be able to operate from a maintenance standpoint and from a healthcare association standpoint. It's not much space for patient access. So if you've ever been in the back of a helicopter or trying to transport these patients, you're not really going to be able to do too terribly much. In order, if a patient needs a procedure or something done, the high risk environments, right? So we're landing, and we'll talk a little bit more about the risk associated with flight medicine here in a little bit. We have to take that into significant consideration, and then there's constant debate about regarding the utilization of resources. So, talk about the bad stuff. We got to talk about the good too, right? So, what are the benefits? So, the biggest benefit, and the reason that we're trying to use this more often, is that we're going to be able to get our patients to tertiary care or to the care that they need a little bit faster. We're lowering the total time of transport and the time to team. The other thing from a system standpoint is that we're going to be able to offload, and I think this is one of the biggest things in Kentucky of why we utilize helicopter services so much more, is that we're going to be able to offload some of our ground units for interhospital transports. It is an extension of critical care access, and then as an increased ALS response to our more rural agencies. So the main article that I'm going to talk about, the thing that we're going to review a little bit today, is a meta-analysis review of a bunch of different articles regarding helicopter-based services, looking at outcomes, looking at utilization, and reasons why they're used. When I talk about anything, I really kind of like to talk about the history and how we even got here. So, flight is pretty new in the grand scheme of things in general. And so, in 1917, it was the first actual French aircraft that was used to move patients from the battlefield to helicopter or to hospitals. So in World War II, the U.S. alone transported over 1 million patients, and they had a mortality rate of about 4 in 100,000, which I think is pretty darn good. We didn't really start using rotary wing transport until 19 for Vietnam. That's whenever it expanded into civilian services, right? And so already by 1978, there were 20 helicopter EMS services initiated throughout the United States. Now, I'll use some terms called rotary wing versus fixed wing, which I think most people know. But rotary wing is a spinny thing on top, right, the helicopter, and then fixed wing is what we think of the traditional plane. So the difference between the two is that their speed of a rotary wing is going to be a rotary wing transport is going to be around 150 miles an hour as opposed to 500 miles an hour of a fixed wing. We're going to be using shorter distances for helicopters as opposed to fixed wing as well. You're going to have the rotary wing is going to be typically medic and nurse type setup. You will very rarely have a physician on board, depending on which type of where you're at in the United States these days, as opposed to fixed wings. That those are going to be more for like specialized transports, longer distance transports. They're going to have they might have a little bit more of a specialized team with them, and more often we'll have a physician on scene for or in part of the group for those. From a altitude of travels, that your rotary wings are going to stay around 2,000 feet, and obviously the fixed wings are going to be up to whatever they're flying at, but they're going to be pressurized around 6 or 8,000 feet. That matters from a physiology standpoint. What happens with the patients in transports, depending on what disease process you're transporting them for. Knowing how physiology is affected by this is an important thing to take into fact. So I mentioned space. These are some of the types of helicopters and planes that I was on during fellowship. So this was survival flight. This was the crew that actually came and picked up that patient out of Talladega. They had a decent sized helicopter. This is the back of a Hawker 800, which is what is over here on the right. This is actually a picture of the bay in Birmingham, Alabama, where we did fixed wing transports. So you can see there's really not much space. This is the space of an actual transport that I was on. This is what we look like most of the time. We were going to this. This is actually I was just telling Dr. Hilty about this. This is a case where this is a baby buggy. So we were on the way to Poland to pick up a 28-day-old that was intubated in a congenital heart kit and bring him back to Charleston, South Carolina. So we we picked up the patient in eastern Poland, as close to Ukraine as we could get, because the kid was actually in Ukraine. Drove back or flew back 26 hours straight, all the way to South Carolina. So this small space, you get really comfortable with the people that you're with. And actually, the mom, there's a small couch right next to us. The mom drove back with us the entire way. So you can see how this type of transport, it can be pretty complex, and making sure that you have all the right equipment before you get there is extremely important. So why do we do this stuff? So why do we make these types of transports? So 90% of them are going to be around, or sorry, most of them is going to be scene response. And I think it's important to know that we'll say a lot of times like 90% of the people live within a level 1 trauma center, and is that 27% of those people require a helicopter in order to be able to get there. So it's an extremely important resource for those patients that really need access to care. Interfacility transports are highly utilized here in Kentucky. Specialty care from the need for intra-aortic balloon pumps, ECMO or ROBOAs, and then evacuation, which I think we're seeing in the past week with all the floods that we have in eastern Kentucky, with the Red Star Group and the Kentucky State Police to help evacuate our patients out of those needs. I mentioned here just to kind of give you an idea of all the stuff that you're trying to, not only are you trying to provide patient care in the back of a helicopter in a very cramped space, but all the stuff, the equipment that you need in order to be able to provide that care. There aren't any true set guidelines by any international organizations of what you have to have. There are a lot of some recommendations. This is a list of those. The other thing that I think is important to note is the standards and regulations of flight-based medicine. Is that the Association of Critical Care Transport has a comprehensive, consistent standards, and the Commission of Accreditation and Medical Transport System, they have accredited or had 161 air and medical ground services in January of 21. There's not much oversight. There's no true anybody can set up a helicopter service kind of anywhere that they need. There's no oversight in the overall direction and planning of that, and that's why you see, especially in Kentucky, where we use this fairly often, we have a lot of helicopter-based services, all kind of serving a similar region. One thing that may not be as important, but is important to know if you run an operating system or are interested in getting into the helicopter-based system, is that the operation of the helicopter and everything related to flight and the medical services are separated. So a hospital can own a helicopter or can own an agency that provides helicopter services, but they might not operate the actual helicopter itself. So they can partner with a separate group that owns like the Part 135 operator, and they run the operations of the aircraft and employ the pilot. So how are these systems set up? 67% of these crews, especially the rotary wing services, are flight paramedic and flight nurse. These, especially the ones that we have at UK, the neonatal transports, are restricted only to inter-hospital transports. So the certificate that our neonatal team has is that they're only going from facility to facility. They're not making scene runs whenever they're getting called out. On average, about 54% of overall transports are inter-hospital transports, and 33% are scene runs. So how is this distributed, and how do we utilize this as a nation? Is that we're increasing our number of air ambulance claims. This is insurance claims for air ambulance in the past 5 or 6 years from 2016 to 2020. So it's increasing pretty significantly, over 30.3% from 16 to 2020. And some of that is that they believe that it's due to a lot of these rural hospitals that are closing, is that we have a higher need to be able to bring patients further distances requiring helicopter transport. So this is a percentage of all claims. So this is another picture of pretty much the same thing, saying that this is ground transport, this is helicopter transport, that it's increasing over the past, in that 5 years. What's also increasing is the cost of transport. So these are charges, not actually reimbursement, but the average charge for a fixed wing transport rose 27%, and rotary wing also increased about 22% from that time of 2016 to 2020. Moving back to kind of why do we transport these patients? What are we most likely dealing with? In 2016 to 20, the overall complaints were digestive issues like small bowel obstructions, and then heart attacks, strained springs, orthopedic injuries were the common complaints. There was a change in 2020. I don't know if you guys remember, we had something that went through the nation that changed the way we operate pretty significantly. So chronic respiratory disease and COVID-19 had a huge spike in 2020 of reasons of transports. And then again, the other heart attack and digestive issues were 3 and 4, so still up there. This was fixed wing, and then this is just mimics the same thing as rotary wing issues. So from a geographic standpoint, I bring this up especially in Kentucky is because this is fixed wing transport, so this kind of makes sense, right? You're going to use fixed wings, you're going to use planes in our states that have very long distance transport needs, and longer transport times. So Montana, Wyoming, Alaska, Hawaii, all of those use fixed wing transports a lot more often than anywhere else in the nation. Okay, from a rotary wing transport, it also kind of makes sense. It's like those same areas are going to need longer distances in order to be able to transfer patients. So Idaho, Montana, Wyoming, New Mexico, and most of the Southeast is green, right? The low utilizers. But West Virginia and Kentucky are really high utilizers of rotary wing transport. And I think a lot of that is due to the reasons that we talked earlier about lower access to care, being able to offset some of our ground units, especially on the eastern half of the state. Um, so does transferring a patient to a hospital by helicopter-based service actually improve care? 90% of these people, these patients that our rotary wing were ended up admitted to the hospital. So in general, these patients are pretty sick and do require some sort of hospital admission. So I think that's reasonable. And then also to say that during that same time, about 50% of patients transferred by ground were admitted to the hospital. So in all this and all, we talk about the benefits. We talk about how good this stuff is for the patients. We also have to talk about the risk because it is a very real thing, as we've seen, unfortunately, in the past few years. So they're talking in this study or in this meta-analysis. They kind of looked at what causes crashes to happen, and what can we do, and what interventions have we done in order to be able to help decrease this risk. So they had 59 aeromedical transport incidents, is what they call this over the course of that time. 41 recorded fatalities with a mean of about 2.5 a year. So they talk about kind of what some of the things that are common in all of these fatality related accidents. Most of them happen at night. Most of them happen on the weekend, and then most of them something to do with weather or rather what. Important to note that they taught there was an intervention in about 2011, 2012 that has increased some of the restrictions or some of the regulations that talk about flying and kind of what needs to happen. And so those changes help decrease the overall number of accidents that we've had. But the incidence of fatalities was not significantly increased, and there's no really great reason as to why that was the case. So I bring these up. These are real cases of situations that resulted in fatalities. This was a crash that happened not too terribly long ago in 2022 in Hawaii of a fixed wing transport. The next slide is two cases that have happened since I've been out of residency. One happened with a group that I had in Alabama that I worked with pretty closely. These were people that I knew. One of them was a nurse at UAB that picked up patients with this flight service as well. And then we all know the Aeromedical crash that happened out in Kentucky last year. And so I mentioned this. Obviously, this is something hard for all of us to talk about and know because we know these people and we work with them often. But I think it's important to recognize the risk and the dedication these people have to their patients to be able to put themselves at risk every day to be able to do the job that they need to do. This is just kind of further explaining some of the risks that are associated with these accidents. So most of them happen with some sort of impaired visibility. Half of them happen with some sort of equipment failure, and then pilot error happened in the majority of them. I left out another study just to not overload us with a bunch of papers in this 30 minutes that I have. But there was another that it talks about kind of pilot experience. And so most of the crashes that happened, the pilot had less than 500 hours of experience prior to that accident. Anybody that has over 500 hours has a very, very low likelihood of having some sort of incident. So they kind of put that benchmark of 500 hours of being a truly experienced air ambulance pilot, right? I think that's something to note, not something that we can necessarily control. You can't really say that everybody has to have 500 hours. You can't get to 500 hours unless you start sometime, right? But I do think it's important that they recommend that pilots that have less than 500 hours of transport time is that they should have probably a little bit more restrictions and a little bit more hesitation for the runs that they do. So kind of keep that in mind when we're making these runs, especially night runs, weekend runs, and runs with any sort of weather-related issues. So this is just a slide or a graph depicting the overall number of incidents that are going down, but the fatalities in red has not changed significantly. What causes accidents is from we talk about weather, we talk about pilot issues. One of the main reasons that they postulate that pilots have issues is because they know about what's happening to the patients. So having pilot like non-discretion, they don't really know anything about the case. They don't know what they're transporting. They don't know how sick the patient actually is important because even as focused as you can be and as good of a pilot as you can be, you're going to have some sort of that internal bias to be able to get the patient to the destination a little bit faster, right? So in that transport that I talked about earlier from Poland to South Carolina, the only time that cockpit door was open was when we were stopping and refueling. We had to stop every 4 hours. So they would stop, they'd get out, they go do their thing and refuel, and they get back on. And we wouldn't really talk to them for that entire time, mostly to be able to let them focus on driving the plane or flying the plane, and us focus on the medical care. Okay. Um, from an outcome standpoint, again, I think it's important to figure out what patients, sorry, are best served for flight transport. And I think that it's it's unique in that what they found is that there's no significant increase in overall mortality in patients that got to the hospital in 0 and 30 minutes from a helicopter, saying that those patients probably could just go by ground and get there just as fast and be able to get the care that they need, right? And the same thing for patients that it took over 60 minutes to be able to get to that hospital. And it probably for similar situations, the ground services could probably get them where they needed to go, at least to some sort of access, and then transport or access for stabilization and then transport. What they found was that the patients that would benefit from him seeing transport could get there between 31 and 60 minutes. That's a very, very, very specific subset of patients in the trauma setting that would benefit from flight EMS. So I think that's important overall to try and figure out from a patient selection standpoint who would do best. Okay, let's talk about a couple of these papers. So this is the plane that we flew on, and this was in one of the stops in Greece. So trauma scores show limited utility for predicting in-flight deterioration in aeromedical patients. I like studies that are named like this because it's point, right? It tells you the conclusion before you actually have to do any reading. And so what they use, so this was a study that was based in Australia. It's unique in that they looked at like their large helicopter and fixed wing transport services based, I think, in like southern and southeastern Australia. They had a pretty big mix of the types of transports. So they had transports that went from scene to the hospital, so rotary wing that was less than maybe 15 minutes of transports, all the way to some fixed wing transports from Western Australia to Eastern Australia that took maybe an hour or so. So those didn't make up all like a ton of the runs, but they did have a little bit of the mix. So I think it's good to see. What they use 3 different trauma scores: revised trauma score, a gap score, and then initial shock index. Most of these, I think what is different about Australian-based services and American-based services is that they had a physician on board. 83% of these were rotary wing, 48% were primary retrievals or scene runs, and then 52% were interfacility transports. They had 3,600 patients over a 3-year period, and about 3,000 of them were used for the data in fixed and rotary wing. What they noted is that they were looking for any sort of patient deterioration. So they defined that as anybody that had significant hypotension or that required some sort of procedure, including a surgical procedure. And so they included those interventions as administration of blood products, administration of greater than 250 milliliters of crystalloid, any use of vasopressors, and performance of surgical procedures like a thoracostomy or cricothyroidotomy. So they noted that 18% of these patients developed hypertension. 55% of those that did develop hypertension did not receive any sort of intervention. And they kind of they discussed on why they thought that was, and a lot of it came to be is that the flight crew noted that the patient had a hypotensive episode, but they were about to land, and so they didn't do anything because they were just going to get the patient to the hospital. The other thing that they noted is that the patient tolerated hypotension, so that the flight crew determined that this patient may have had a MAP of 60, but the vital signs otherwise looked okay. The patient looked all right, and they just didn't do anything. And then the next thing that they noted is that the true definition of hypotension, right? So they marked every case in here that the MAP may have been 64, right? And that flight team, through clinical judgment, was like, well, 64 is pretty close to 65. This patient's all right. And so most of those patients were within one or two. Um, I think what is important to note overall from just recognizing any sort of patient deterioration is that none of those scores worked extremely well, like the title says. So they used an area under curve analysis and noted that it was less than zero point 0.8 for every single score that was used. They had the sensitivity for all of them. I think the GAP score had a sensitivity of 61% for predicting deterioration, and shock index, which I hear us use quite a bit over here, had only a 54% prediction of or sensitivity of deterioration. So they also tried to find some subgroup analysis depending on patient injury or transfer status or how long the transfer was. They found that no matter what situation they were in, is that those scores didn't predict what we wanted it to. And so I think that is obviously this is a negative study. A lot of people don't like talking about negative studies, but I think they kind of show and show the importance of us not really having a great idea of how to predict patient deterioration, and so that we always need to be prepared for it, right? So we can't say that, oh, this patient's shock index whenever I get there is good, and so that I think that this patient's going to do well. Is that we note that none of these are really going to be able to help us out tremendously, so that we need to be prepared all the time. I also think it was funny that they mentioned specifically that they couldn't use respiratory rate as a predictor factor because I think 99% of the patients had an initial respiratory rate documented at 18, which seems to be the norm. So the next one is this is a hot topic, and I'm sure people will get fired up about this, or just in general, is that we could probably talk for hours about this. So it was a study down in Orlando, Florida, at Orlando Regional. They looked at direct versus channel video assisted and unchanneled video assisted laryngoscopy and which one works the best. So they recorded 517 intubations. 312 of those were direct laryngoscopy. 126 of them were channeled, and 79 were non-channeled. So they had a nurse and medic team. They were in order to be able to get on their teams, you had to have several years of experience prior to hiring. They all had RSI capabilities. Sorry, and this was a retrospective study, so all of the intubations were left to the discretion provider of which one they performed. What they found is that 28 times the provider started with a DL and then switched to video laryngoscopy of some sort after that. No patients that started in video laryngoscopy switched back to a DL. And then first pass success rate, 76% with DL, 78% with a channel video laryngoscopy, and 92% with non-channel. So I think this is kind of in line with everything that we see when it comes to video laryngoscopy. And I think it's important to also note, while I'm going to talk about how I'm a big believer in video laryngoscopy and how I think that should be our primary use for the large majority of patients, is that they also noted that there's no time difference between the two. Okay, so even in those patients that started in DL and went to VL, there's no overall significant time difference toward intubation. They did note that the number of temps and overall a better overall higher success rate in non-channel video laryngoscopy. And so I think that the reason why a lot of people get hyped up about this. Now I'm a firm believer is that everybody should know how to use direct laryngoscopy and should be well trained in direct laryngoscopy. Okay, I don't think that that's something that we should throw in the trash because, as we all know, with technology, technology fails, and we need to be able to have some sort of backup, right? When you look at all of these studies and a lot of the studies that even from an in-hospital standpoint that talk about video versus direct is that it almost always shows is that people that have more experience with DL tend to do pretty well with it. But what we're dealing with a lot is like our new providers that can get into video laryngoscopy a whole lot faster, right? And they get in and they have the same success rate with very little training as a very, very, very experienced person that is performing DLs, right? And so it's a much, much faster and, in my opinion, safer way for us to be able to have our new providers um, perform intubations. Now, I know that probably triggers some people, and I'm more than happy to talk about it more later. But I think that there's a role for DL, but I think video laryngoscopy should probably be our first route of trial. Uh, the next and last thing I'll talk about is kind of something that I think is important and something that we need to do better in the hospital, but also something that we deal with a lot in transports is that how do we reduce deep sedation and benzo use of mechanically ventilated patients during critical care transport, right? So the goal of this study was that they note that patients that receive deep sedation, the longer that a patient is under deep sedation, it increases their number of ICU days, it increases their ventilated days, and it increases their overall mortality in the hospital. And so, how do we stop that, and how do we kind of combat that? We note that it happens a lot in EMS is because we're trying to get these patients sedated so we can do what we need to do. We can get them from place to place and keep them safe while we're doing it. We mentioned, I've talked a lot about how tight the quarters are in the back of a helicopter or in the back of a fixed wing transport. We don't want the patient moving around. We don't want them pulling on things. And so how do we balance this really deep sedation versus keeping them in a more moderate or light sedation for patient safety, right? So this study really was just kind of looking at can we create a program to be able to educate our providers to be able to really refocus our goals on sedation. So what they did is that they did a pre and post test initiative in order to be able to figure out kind of what could they make a change in their program. They aimed for light sedation with a RASS of around -2 to +1. What they looked at is 407 patients. They used all critical care transport, so 304 rotary wing and 103 ground units. Um, what they found is that 70% of the patients that received deep sedation had no indication for deep sedation in their transport protocols. Okay, and so what they noted is that before that it was 90% of patients without an indication received deep sedation. Um, After they performed an intervention, so after they performed education and really talked with their crews about how to better sedate our patients in a way that is safer for everybody, is that they did see a decrease of down to 63% of patients receive deep sedation. So still a pretty significant amount of people that are getting to this really, really deep sedative state that we don't really want, but it did show kind of that we can, with education, we can help make changes to our overall patient care. So this is kind of an overall picture of their study time. So they started in January. This is when they were just initially talking to their providers about what's going on. They did a didactic session of, hey, this is something that's important to us. This is a change we wanted to make within our agency, and we don't want to deeply sedate all of our patients all the time. They saw a slight spike after that, but then they started to get a decrease. You have a little bit of a lull where the providers may have forgotten about it. It starts to increase. They change their guidelines to say, hey, we're not going to do this anymore. If a patient doesn't meet deep sedation criteria, then we're going to not try and not do that. And then they got a decrease. So overall, they started up here and got down here. So this is a plan, do, study, act type intervention. So they planned it, studied it, acted, and then tried to figure out um, did they make an impact. So overall, this is just showing that if you try hard, you can make change within your agency overall. So um, I'm finished talking now. I think I went over a little bit. I'm sorry, Walt. But flight's cool. I really enjoy it. I'm not directly involved with any flight agency here, but I'm more than happy to talk with us about any of you guys. So this is our patient that had the STEMI. He actually had a slight run of VTAC as soon as they were loading him up. Went to UAB, got cath, had 100% LAD occlusion or RCA occlusion, and walked out of the hospital a couple days later. Sure. It's much higher in aeromedical services. Mhm. Not that I know of. And I kind of like I took a slide out of here just to kind of talk about that process of how flight crews are even initiated to a call. You have your scene response, and then you call for a flight, and then they have to be dispatched, and they've got to check. Then the pilot's got to check the weather. The team's got to get their stuff together. So it definitely takes quite a bit of time. I don't know if there's anything specifically looking at the entire process. Mhm. Yeah, yeah. I, I think it's probably going to be patient dependent. I mean, obviously, if you think that if it's a trauma patient, like I said, that can kind of fit in that guideline. You think that they can get there within less than an hour. That might take you a little bit longer. If you know you're going to be on scene, if it's a prolonged extraction or you're going to have a little bit of a longer scene time, it may be more beneficial to be able to get the flight crew there and get those wheels rolling, especially if you can get them there faster than an hour that hour period. Thank you all.